Emara. In locally advanced rectal cancer, can MRI predict a response to total neoadjuvant chemo-radiotherapy?
Bismillah ar-Rahman ar-Rahim. First of all, I'd like to thank organizing committee and chairpersons. I'm Doaa Emara, Assistant Professor of Radiology, Faculty of Medicine, Alexandria University. My talk today is in locally advanced rectal cancer. Can MRI predict response to total neoadjuvant chemoradiotherapy? As we know, colorectal cancer is the second leading cause of death among cancer patients. And despite screening program, there is a relatively high rate of recurrence among these patients after surgical treatment, reaching up to 21%. Neoadjuvant concomitant radio and chemotherapy followed by total mesorectal excision is considered as a standard treatment for these cases with superior outcome and sphincter preservation. Recent advances with high-resolution MRI, play an important role in diagnosis and staging of rectal cancer patients and to assess response to total neoadjuvant therapy, which is a key factor in considering organ-preserving surgery. Response to therapy should be assessed both morphologically and functionally. Development of non-invasive response evaluation model could help to identify patients with good response who are likely to benefit from surgical management and those who will go for watch and wait or non-surgical strategy. The aim of the study was to assess the use of MRI quantitative techniques, diffusion-weighted imaging, and MR spectroscopy as non-invasive, non-contrast sequences in diagnosis and staging of rectal carcinoma, and also to predict response to treatment. The current study included 38 patients with pathologically diagnosed rectal cancer who were planned to receive total neoadjuvant therapy. Baseline non-contrast MRI was done using routine sequences, diffusion-weighted imaging, and MR spectroscopy, and the same protocol was repeated 6 to 8 weeks after end of treatment. Choline signal-to-noise ratio was measured, and if it's 3 or more, it's considered diagnostic for rectal adenocarcinoma. Assessment of response by measuring ADC, choline signal-to-noise ratio, in addition to morphological assessment by conventional sequences. And then the patients were referred to surgery, and the radiological response was compared to the post-operative pathological response. The current study included 63% females with mean age 54 years. And this table summarizes the ADC value of both groups, well to moderately differentiated tumors and poorly differentiated mucinous tumor. ADC before treatment in the first group was 0.83, increased after treatment to 1.05, and this is statistically significant. While in the second group, there is no statistically significant difference between before and after treatment. This work curve and table shows the accuracy of diffusion-weighted imaging and HCE in predicting the poorly differentiated tumor with cutoff value of ADC 0.85 with high sensitivity and specificity. This table also shows significant association between having choline signal-to-noise ratio 3 or more and complete response to treatment. And now I'll go through some of our cases. This female patient, 65 years, diagnosed as rectal adenocarcinoma, axial T2 weighted imaging, diffusion-weighted imaging, and the ADC, and this is fusion of both T2 and diffusion just to augment the pathology. The lowest ADC before treatment was 0.8, and this is after total neoadjuvant therapies. There is good response with decreased size of the mass, decreased diffusion signal, increased ADC value up to 1.4, and this is a case of good response. Another male patient, 44 years, again with rectal adenocarcinoma in diffusion and ADC was 0.8. And this is the T2 and diffusion of T2 and diffusion. After treatment, there is decreased in size and increased ADC value reflecting the decreased cellularity. The ADC reached 1.8 after treatment. Axial T2, sagittal T2, diffusion and ADC map of this patient showing a sizable mass lesion with exophatic component, nicely demonstrated here in sagittal weighted imaging, and infiltrating the perirectal fat with pathologically enlarged lymph nodes. This is the endoscopy of the same case. And this case showed the adequate response to treatment, and even after surgery, there is no residual or recurrent masses. Regarding spectroscopy, this is a choline peak in patient with rectal adenocarcinoma with choline signal to noise ratio up to 7, and after treatment there is marked decrease in the choline peak, also in signal to noise ratio reaching 1.2. Another patient with good response. Female patient, 47 years, pathologically diagnosed as mucinous rectal adenocarcinoma, axial T2, showing high signal intensity of mucin contents. Diffusion weighted imaging and ADC, there is high ADC value. And unfortunately, there is no response to treatment, and the mass after treatment increased in size with no changes in ADC. So in conclusion, MRI using non-invasive, non-contrast diffusion-weighted imaging and MR spectroscopy by measuring ADC and choline signal-to-noise ratio can accurately diagnose rectal cancer, differentiate tumor grade, and predict response to treatment. Low ADC value is an indicator of good response to total neoadjuvant therapy. Thank you.
Thanks, Dr. Doaa. Our last speaker is Dr. Mu'taz Abu Zaid, role of magnetic resonance, cerebrospinal fluid